I'm an internal medicine resident in Baker Health System, St. Joseph Hospital, Tampa, Florida. The title of this poster is New Onset Microscopic Polyangiitis Triggered by COVID-19 Infection. Introduction. The COVID-19 pandemic has had a major impact on health, ranging from mild illness to severe conditions like ARDS and long COVID. COVID-19 is known to cause endothelial damage and immune dysregulation or cytokine storm, which could precipitate autoimmune conditions like microscopic polyangiitis or MPA. MPA is a small vessel vasculitis affecting the lungs and kidneys, marked by necrotizing inflammation and absence of granulomas. It often leads to rapidly progressive post-immune glomerulonephritis, potentially resulting in end-stage renal disease, and can cause diffuse alveolar hemorrhage or interstitial lung disease. Viral infections, including COVID-19, are associated with new autoimmune phenomena and vasculitis. This case describes a rare case of new onset MPA suspected to be triggered by acute COVID-19 infection. Case presentation. An 84-year-old African American male with past medical history of hypertension, hyperlipidemia, type 2 diabetes mellitus, transient ischemic attack, right nephrectomy for renal cell carcinoma 20 years ago, and stage 4 CKD who presented with productive cough and hemoptysis over the past 4 days, accompanied by pleuritic chest pain and weakness. No recent travel or sick contacts. He denied any smoking or illicit substance use. Family history was non-contributory. Vital signs were normal and physical exam was unremarkable except for bilateral bronchi and auscultation and productive cough. Chest x-ray showed right perihilar and basilar mass-like airspace disease. CT chest without contrast revealed multilobar ground glass opacities and mediastinal adenopathy. Lab showed markedly elevated creatinine, blood urea nitrogen, and potassium, as well as raised in ESR and CRP. Patient was also significantly anemic. COVID-19 RT-PCR was positive. Urinalysis showed proteinuria and hematuria. Further workup showed a positive ANA, positive ANCA, low C3. He was started on emergent hemodialysis and treated for COVID pneumonia. A renal biopsy showed post-immune necrotizing and crescentic glomerulonephritis consistent with MPA, which was treated with steroids, cyclophosphamide, and 5 sessions of plasmapheresis with subsequent clinical improvement. Pertinent labs and imagings are the following: creatinine of 15 mg per deciliter, BUN 119 mg per deciliter, hemoglobin 6.5 grams per deciliter, potassium 6 milliequivalent per liter, ESR 73 mm per hour, CRP 6.6 mg per deciliter, COVID-19 RT-PCR, which is positive, urinalysis revealing proteinuria and hematuria, and ANCA positive with a titer of 1:320. Figure 1A is a CT chest coronal view and B cross-sectional view showing multilobar ground glass opacities on admission. Figure 2A and 2B are both renal biopsy, A showing fibrinoid necrosis of the glomerulus and B showing cellular crescent formation. Discussion. The temporal link between the COVID-19 infection and the onset of MPA suggests SARS-CoV-2 may trigger autoimmune conditions. In this presentation, the multilobar ground glass opacities represented COVID pneumonia and or diffuse pulmonary hemorrhage, and the rapidly declining renal function required emergent dialysis. An immune workup showed positive p-ANCA, and biopsy revealed post-immune necrotizing and crescentic glomerulonephritis, confirming microscopic polyangiitis. Management includes corticosteroids with cyclophosphamide or rituximab and plasmapheresis, followed by maintenance therapy with azathioprine or low-dose rituximab. Treatment usually lasts 18 to 24 months, longer for high-risk patients. Conclusion. This case emphasizes the need for clinical awareness of new onset autoimmune diseases like MPA in patients with COVID-19 infection, in patients presenting with significant hemoptysis, multilobar ground glass opacities on imaging, and severe renal insufficiency.